Great, thanks. Thanks, Regina. Yeah, I want to thank Dr. Crow and the team for giving me the opportunity to speak today. Truly honored to be here, obviously, and hopefully something I say is helpful to this group. And I often find that I learn more from the group than I'm able to communicate sometimes. So, as you can see on the title, today we'll be talking about primary care and integrated behavioral health. We're really focusing on integrating behavioral health work given value-based contracts, and sort of how I think about doing this from my time as a chief medical officer of a federally qualified health center and now at our academic primary care practice. And so, uh, in addition to giving you some background about myself, today really we'll be speaking about primary care through the lens of value-based care. And, when I say primary care, I am also talking about, our behavioral health consultants, our community health workers, our social workers, nurse care managers. There's such an integral part of the work we do in primary care that it's very hard to sort of delineate one from the other, especially nowadays. And honestly, I contend that collaborations within a large or a small primary care practice are going to be important for us to enhance the health of our patient populations. And that's really where my focus and my passion is. And honestly, to be able to understand how to do this, we need to understand how to align the work to both the contracts and the needs of our community. So that's kind of what I'm going to focus on today. You see our other session objectives, which were on the notice in terms of talking about measures, aligning work to those measures, and then thinking about staffing. And we'll definitely talk about all of that too. One of the important reasons we have to understand the current state of primary care payment mechanisms is that the number of primary care practitioners doing this type of work are growing. And CMS and CMMI have stated that their goal is to enroll the majority of our patient population in value-based contracts moving forward. So we see and we know that this work is going to become more and more important as the contract penetration around value-based care, it also increases nationally. And given the growing number of practices that are doing this work, integrated behavioral health is going to be much more important. One of the articles I really like in this space, and in some ways how I've sort of structured the talk today, really comes from an article released back in 2014 that talks about the necessary components for creating an integrated behavioral health program in patient-centered medical homes. And I like to say, and I like to think that a lot of the primary care that's happening these days across the country surpass what's necessary to be considered a patient-centered medical home, both from NCQA and the JCAHO perspective. But ultimately, this article that you see in front of you here does a really good job at really breaking down the important components of doing integrated behavioral health well, so that it's sustainable. But a little bit about myself first. I'm from Cleveland, Ohio, originally. I'm a family medicine physician. I did my residency at Mayo Clinic in Jacksonville, Florida. And during my training there, I became very passionate about patient safety and quality of care. So much so that I decided to do a fellowship focused on that work. I was an academic medicine fellow at Boston University School of Medicine and Boston University School of Public Health, where a lot of my work was focused on social determinants of health and decreasing hospital readmissions, specifically in patients with depressive symptoms or with overt depression. And this is also where I got my master's in health services research as well. A huge sort of step in my career is following fellowship. I got a job as chief medical officer of a federally qualified health center in Mattapan, Massachusetts, which was about 20 minutes south of Boston. And there I led the implementation of multiple services, including integrated behavioral health, integrated HIV care, substance abuse counseling, and treatment. And, this is a picture, I love this picture. This is an image of our grand opening of the Mattapan Community Health Center Behavioral Health Services Department. I helped write grants that awarded the health center dollars from both private, state, and actually federal dollars to build our integrated behavioral health program from scratch. We built a team of clinical psychologists, LICSWs, MSWs, community health workers, substance abuse specialists, trauma-informed specialists, and psychiatrists, really to support our kind of high risk, high complexity, low income patient population at this FQHC. And really, really great work. And the program continues to this day. After that role, I came here to San Antonio. And here is one of my main roles is executive director of our primary care center. And so this is a picture of our leadership team. Includes our medical directors and our practice managers from all of our locations. Really a great team. And this is a picture from our most recent retreat, and it depicts all of our primary care clinicians, including some of our leadership as well. And they represent really what we like to think is a strong team-based primary care culture that's really spread throughout Northwest and far Northwest San Antonio. Each of our locations have very similar processes and workflows and metrics, but each, as many of you understand when you have multiple locations, each of our locations has its own feel and uniqueness as well, which is really nice, really neat. And so, a lot of the discussion today will be about clinical operations, right? How do we operationalize our integrated behavioral health work? So what you need to understand in terms of my current experience is, well, what does clinical operations look like in our current practice? So our primary care center has general internists, family medicine physicians, pediatricians. We hire primary care sports medicine physicians, so we have a sports medicine service line, geriatrics, and obesity medicine as well. We have extenders in terms of nurse practitioners and physician assistants, and they have academic appointments at our School of Medicine as well. They are important parts of our team. And we have a number of behavioral health consultants. So these are clinical psychologists who help with behavior change. We also have a team of central nurse care managers, community health workers, and a group of folks that we call quality improvement specialists as well. We staff to MGMA staffing ratios, per 10,000 work RVUs. That helps us align our operational team, front office and back office, with the team sort of doing the clinical work directly with patients. We have a clinician incentive model that has three main components: productivity, and we use CPSC targets for our productivity benchmarks; quality metrics, in some ways, annually, those quality metrics are selected by our medical directors; and then sort of a shared savings component to budget that we utilize in terms of our clinician incentive model. It's something we call expense efficiency here in our primary care center. Our patient population is quite diverse, but mainly kind of fee-for-service, commercially contracted patients. We have some value-based contracts with managed Medicaid through the TIPS program, which many of you might be familiar with, Medicare Advantage, and then we have a MSSP ACO called Regional Physician Network as well. So that's sort of the overview, kind of high level of our primary care center, just from sort of an operational standpoint. Our practices are preparing for the opening of our first hospital kind of owned and operated UT Health San Antonio Hospital here in San Antonio. And as many of you probably already know, having a hospital as part of your health system really does allow for a lot of different opportunities as it relates to developing a model of care that makes sense for a community. And so it's something we're really excited about. Our main hospital partner here in town is a university health system, which many of you might already be familiar with. Another exciting part of my role here at UT Health San Antonio is as Senior Medical Director of our medical management team as part of our Center for Population Health and Value-Based Care. Here, we oversee a team of nurse care managers, community health workers, who, in essence, take care of our patients when they are not within the walls of one of our clinics, right? The picture here on the right is a little older, but our team has really grown. And this is a picture of our nurse care managers and community health workers who help with patient transitions of care from emergency rooms and hospitalizations, care coordination, chronic care management, medication adherence, and then they also help screen and connect patients for issues related to social determinants of health, and we need to connect them with a community-based organization. So that's sort of our team that helps support not just our practice patients, but also the patients in our extended family, our UT Health, a regional physician network, accountable care organization. So that's a little bit about me. I wanted to spend a few minutes just high level, and I'm sure many of you are sort of familiar with this topic already, but at a high level, just talking about value-based care, and sort of foundationally how I think about it. It's a little different, perhaps a lens than folks are used to hearing about it. But I think it's important as we think about staffing and utilizing behavioral health models to do value-based care well. It's sort of important for you to understand how I approach it. So pretty simply, right? Value-based care is this shift away from fee-for-service care. I think if you talk to a lot of people, I don't think anyone believes fee-for-service care and fee-for-service payments are going to go away completely. But more and more primary care practices and other organizations are moving towards value-based care or working with their payers, state, commercial, or federal, to develop value-based care models that make sense for their patient populations. Back in the 90s, early 2000s, we were worried about, quality metrics and quality measurement. Over time, as our ability to do this measurement and do these cost projections has improved, more and more value-based contracts, including what CMS is looking to do, are moving towards taking on more and more risk at the kind of health center level. This allows for higher rewards possibility, but also increases the responsibility we have for our patient population, including when they're not in front of us in the clinic. And this is the piece where I feel like integrated behavioral health models can really have an impact. So when I say fee-for-service care, what do I mean by that? Well, success in a fee-for-service care model means a lot of service, means a lot of volume. And so oftentimes when we think about fee-for-service and what matters, the value, meaning the quality and the cost of the work we do, is often overshadowed by the number of encounters we do in the clinic. And this, as you can imagine, leads to unintended consequences and sometimes even perverse incentives, right? Because you can see a patient a lot in the clinic, but if they're not getting better in a fee-for-service model, that doesn't necessarily matter. So how do we define value-based care then? The value equation, I think, is well known by now. Value equals quality divided by cost. And like any math problem, to increase the number on the left of the equal sign, you either need to increase the numerator or the quality number on the top of that equation or decrease the costs. And in value-based care or in value-based contract, the quality and outcomes of certain activities are incentivized, right? You can see a patient once or you can see a patient 13 times. If they are better at the end of a defined time period than they were when you started seeing them, then that is a high value care you deliver, and that potentially means higher revenue for an organization, right? But the value equation applied to the real world can feel quite complicated. And this is sort of where I want to spend a little bit of time. Quality is, so we need to think about, well, how is quality and cost being measured in the real world? Quality is measured via often pre-identified quality metrics. And those quality metrics can range from doing annual wellness visits, cancer screening, checking hemoglobin A1C in the clinic. That's what we call process measures. Did it happen or did it not happen? Or they are measured by more difficult to hit, but often more highly incentivized outcome measures. The hemoglobin A1C, was it under 9 or not? Was the diabetes controlled or not? Was the blood pressure controlled or not? Did the depression symptoms get better or not? What was the patient's experience of the healthcare organization? These are called outcome measures. So when we think about quality measures, I like to think about sort of the Donabedian model, where you have sort of structure, process, and outcome. And so process and outcome measures are often contained in value-based contracts, right? So this is quality. And like in the equation, we want to, do our best to increase the quality of care as defined by those measures. Now, cost, or another way of saying cost, is utilization. It's a little trickier, right? Oftentimes, cost or utilization are harder to measure. In some ways, more difficult to predict and harder to control, right? Whether or not a patient goes to the ER or into your clinic, whether or not a patient, is using home health appropriately, or utilizes, inpatient rehab for the correct time period related to their needs. All of these things are tougher to measure oftentimes, but they are important components of every value-based contract. And so these are sort of, here's the list. I like to break it down by, acute costs, post-acute costs, and community costs, or utilization events. Important thing to highlight, though, is a lot of cost in healthcare is necessary. I'm not saying all cost is bad. I think our goals as clinicians, as leaders, as members of teams, of care teams, is to identify opportunities to avoid unnecessary or avoidable utilization events in healthcare. Right? Now, I like to add another component here, and this is sort of the adjustment that many value-based contracts tend to have. So value equals quality divided by cost, yes, but it's adjusted by two factors. One is, how big is your patient population? How many patients is your organization or is each clinician managing for that payer? And second, how complex is that patient population? And, panel size is easy. It's, the number of unique patients that we have for any given payer under contract. But panel complexity is a little trickier to measure. CMS has identified specific diagnosis codes, which it has labeled as hierarchical coding category codes, which basically means that CMS has identified specific diagnoses, which, if a patient has one of these diagnoses, they are at risk for being highly complex or having increased costs compared to patients without those diagnoses. And so those are important factors that we consider in primary care, especially nowadays, to risk adjust our patient population, okay? So this is sort of how I like to think about value-based care. It's not as simple as value equals quality divided by cost, right? In practice, it's value equals quality divided by cost, adjusted by the number of patients and the complexity of those patients that we're caring for. And I'm going to come back to this equation. Again, this is the way I think about it. I'm going to come back to this equation quite often as we think about how to overlay on top of this the work of an integrated behavioral health or an integrated team of extenders in our practices. Okay. One thing to call out, though, and it's just important for us to kind of say out loud in these conversations, is, one perhaps problem with value-based contracts is that value-based contracts assume that the reason for the high costs in the US healthcare system are related to clinicians and the fee-for-service incentives that drive many business models. There is data to suggest out in the literature, especially sort of in the kind of healthcare finance literature, in the academic healthcare finance literature, that the high cost of services, medications, and administrative costs in the US are the true cost areas that really need our attention. And I bring this up mainly because, what I am describing is basically primary care operating within the constraints of our value-based care contracts. But there's a whole other area of healthcare that's happening that's high cost that the things that I'm saying today really does not address. So if value-based contracts are the solution to decreasing costs of care in the US, all I'm saying is that there are other factors to consider as well. So how does this really all work, right? In general, we look to increase quality and decrease costs of care. But I'd like to kind of dig in a little bit in terms of how this works in practice. And I'll use sort of the ACO, the kind of CMS or Medicare Advantage programs as an example of how we think to do this in the next few slides. But I think the basic tenets of how value-based care work are true, even if your patient populations don't necessarily fit neatly within these buckets of contracts. All right, so the Medicare Shared Savings Program, or MSSP, includes traditional Medicare patients. And so looking at our value equation, let's focus on the quality component of the equation. In the MSSP program, there are groups of quality metrics, essentially, again, following along the Donna-Bedian model of quality that we look at here. One of them that we look at specifically is patient experience. I think many of you probably have to report that in some way. Another quality metric, again, are outcome measures. And the outcome measures that we focus on for the MSSP program include things like depression remission, 30-day all-cause unplanned readmission rate, diabetes control, hypertension control. Again, nothing out of the ordinary as it relates to the measures by which our quality or our ACO contract is looking at. And then we have process measures that include things like assessing fall risk. Did someone get vaccinated for the flu vaccine this year? Colorectal cancer screening, breast cancer screening. As we move from quality component of our equation to the cost component, you can see that all areas of cost, both necessary and avoidable, are tracked. And this includes things like hospital admissions, readmissions, as well as other areas like home health, certain medications, and high-cost labs. I would note here, and this is sort of important, is that there's a lot of research to suggest that quality and costs are not independent of each other. So, it's important for us to note that the relationship between the numerator and the denominator of this value equation is quite complex. So, the reason I say that is because I am oversimplifying this, but I think it's good to sort of understand in simplest terms kind of how these value-based contracts work. Medicare Advantage programs work somewhat differently than the MSSP program, especially as it relates to impact on risk adjustment, as well as shared savings as it relates to the risk adjustment piece. Nevertheless, you can see a similar list of process and outcome and quality metrics here. Note that medication adherence and completing a medication reconciliation encounter with a patient post-acute facility discharge or post-hospital discharge are really important measures to this particular Medicare Advantage plan. MA plans have similar, but in some ways more impactful risk adjustment and total cost of care metrics. You can see here an example of data we receive monthly from one of our payers. Includes everything from admissions per thousand to referrals per thousand, patient complexity scores, things like that. And value-based contracts utilize financial incentives to drive system and clinician behavior. A few of those examples are here. So depending on the plan, quality and utilization bonuses, incentives for risk coding, star scores, ratings, and even stipends to support things like enhanced care coordination are drivers to motivate clinicians and, in some examples, in patients towards value-based activities. Right? Shared savings is an important component of most value-based contracts these days. And so many of you may already be familiar with capitation and shared savings, but I just wanted to highlight this just a little bit here. You can think of capitation and shared savings almost like an allowance, right? If you are given $500 to take care of a patient and you spend $400 to take care of that patient, you have a potential to collect a proportion of that $100 you saved. But if you spent $600 to take care of a patient that the payer thought would cost $500 to take care of, you might be on the hook on that $100 more that you spent to take care of that patient. Ultimately, the goal in a value-based contract is to take care of the patient as best you can, given the target benchmark that was calculated to help determine how much money it would take to take care of that patient population. And it's a really important component to understand about value-based contracts because it drives how much in revenue a value-based contract might be able to distribute to your healthcare organization or your healthcare organization's partner. All right, so our value equation has other components too that we talked about. The number of patients we manage in primary care, is the panel size. So how many patients are we taking care of? And the complexity of the patient population can also, again, attenuate our benchmark. So in other words, assuming the same number of patients, a benchmark for one health system could be higher than another if that system had a higher complexity patient population. And this complexity is measured and driven in large parts by the HCC coding that I talked about earlier on. And so I guess the final point here is you can see how patient attribution matters in value-based care. This seemingly simple act of you knowing who your patients are and your patients knowing who their primary care team is matters because with attribution comes panel size and panel complexity number. And that's a really important component as it relates to value-based contracts. All right, so we talked about the value equation. We've talked about how it's quite complicated in practice. We've also talked about how each of these factors can contribute to determining whether or not by measurement the organization is actually doing a good job at producing high value care. But the important thing then is, how does a value-based contract actually turn into revenue for a healthcare system, right? That's kind of part of the important part of what we're talking about here. So the reason practices are changing how they deliver care is because both success and financial performance in these models are related not to seeing more patients, but by improving patients' quality of care and figuring out how to coordinate care to manage the total cost of care for those patients. And you can see that for shared savings in these contracts, not only does quality need to be at a certain level, right? But shared savings is contingent on managing costs of patients compared to a risk-adjusted benchmark, okay? So I like to kind of go through these slides one more time together here. So value equals quality divided by cost, adjusted by the patient population's size and the patient population complexity in a value-based contract, right? So we really need to do our work to align our activities in our organizations to increase quality, decrease avoidable costs, and leverage that group of activities to either increase panel size or increase our documentation of patient complexity, or both, right? And that, doing any of those, increases value. And then shared savings, meaning, okay, what dollars are distributed back to the organization is contingent to a risk-adjusted cost benchmark, right? This has to do with our coding and the complexity of our patient population, adjusted by the size of that patient population, more complex patients or, more patients in general. We subtract from that total how much we thought it was going to take, how much money we thought it was going to take care of that patient population. And then, and only then, do we multiply that. And again, this is based on the contract that your organization has, by some sort of ratio of our quality metric performance, right? So you actually have to demonstrate saving some dollars compared to the estimated actual cost before the performance on those quality metrics is figured into the patient population. That's an important component to understand. If the cost of taking care of a patient population far outsizes how much you thought it was going to take care of that patient population, in a shared savings contract, it almost doesn't matter necessarily from a revenue standpoint if you did a good job on the quality metrics, right? That's something that's important to realize about these contracts. All right. So knowing all this, let's get back to our session objectives, right? So with these factors as our foundation and our starting point, let's answer, our objectives a bit. But we have to realize that, the next few slides are really contingent on a few things. Number one is where you and where your organization's leadership are on your value-based care journey, right? Are you at the beginning? Are you at the middle? Have you been doing this for 20 years? That matters. Second is, what sorts of value-based contracts do you have, and what proportion of your total revenue comes from those contracts? There might be a lot of work happening in the value-based care space in your organization or, a partner organization, but if a lot of the revenue is still coming from fee-for-service work, that's important to know, because you're going to have to leverage your arguments towards value-based care and increasing staff time to do value-based care, knowing that a lot of the revenue is still coming through the fee-for-service side, right? And then lastly, it's about risk tolerance. Value-based contracts are sort of a high risk, high reward situation. The more risk you take on, right, the more dollars and revenue you may be able to have to invest back into the organization and staff. But that higher risk does come with more possibility that your organization might overshoot in terms of how much it costs to take care of high-risk patients. And that's an important thing to understand. All right. So these are the objectives sort of at the beginning of the talk. And I'll just kind of go through these here, one at a time. So number one was review clinical and outcome measures to anticipate the care needs of the entire patient population. All right. This is something we kind of have to back into, right? We've already talked about the kind of value equation. We know which factors, and again, it's going to be different for every organization. We know which factors we need to improve based on our value-based contracts or based on our HRSA contracts, all of the contracts that have these quality metrics. You sort of have to start with the metric and move backwards to be able to start this conversation. And so, so given the value equation that I talked about, we have certain metrics to improve, right? Quality metrics, we have utilization metrics or cost, patient population size, and a patient population complexity, right? And often complexity has to do with how well we are documenting or how well we are coding. It doesn't necessarily mean, we're going out and trying to get more complex patients into our practice. Oftentimes, it's just about documenting and getting credit for the work that we are already doing. But to start that conversation, your data input and data collection and reporting strategy matters. Meaning, how do you collect clinical metrics such as blood pressure control, vaccination completion, even things like depression remission? How does your organization collect metrics around medication adherence, hospitalizations, and ER visits, especially ER visits for ambulatory care sensitive conditions, which, these utilization metrics can be tricky to track, especially if your electronic health record or if your data keeping process is not communicating directly with urgent care facilities or emergency rooms or hospital systems that your patients go to, right? The other thing that's important here is your reporting strategy. And in that reporting strategy, I also include thinking about defining who knows their own data, right? And perhaps the data of others in the organization. How easy is it for a clinician to know their performance in the metrics that you think are important here at any given time? We cannot improve what we are not measuring. All right. So determining how care extenders and enhancers are utilized to support population health and care coordination. And so now that you know what metrics to improve and how you are performing on those metrics, in some ways you have to develop a strategy and aligned tactics to make the change necessary in those metrics to help patients and perhaps even create shared savings or generate revenue. And so we need to make sure that as we are defining, is it the behavioral health consultant, the clinical social worker, the community health worker, the nurse practitioner, how are the activities that those staff members are doing, how are those activities aligning with accomplishing the goal of improving quality, decreasing utilization, increasing patient population size, or improving documentation of patient complexity, right? I'll talk about a few examples of how that's done here in a bit, but I think, again, we are in some ways backing into the job description of these positions as it relates to integrated behavioral health or integrated care models. We're backing into the work a little bit by first defining the metrics that we need to impact, okay? All right. Determining investment amounts of new staff, including the cost of training, and prioritizing adding care extenders and enhancers to primary care. So, given your organization's contracts, data, how improvement in value-based care metrics will be impacted by the skill set of the physician, we need to determine sort of what makes sense in terms of this, right? So let's think about a behavioral health professional, for example. Here in our practice, we have 3 clinical psychologists that are called behavioral health consultants. And we identify one of their activities as behavior change. We have a referral order for our behavioral health consultants that allows our clinicians to define the diagnosis that we want those behavioral health professionals to help support the primary care physician to impact. It could be anything. So you might have a contract with a payer that that pays for improved diabetes control, for example. So an example of how to navigate the activity of a behavioral health consultant in your practice might be to ensure that a lot of the work they're doing is to improve diabetes control in a patient population. So, your reporting process you might want to create reports of patients with uncontrolled diabetes. And what we would do in that instance is we would send those lists of patients with uncontrolled diabetes to their primary care physicians. Their primary care physicians would run through the list, define who perhaps would need to see or might like to see a behavioral health consultant, and then develop a workflow of a referral from that primary care physician to that integrated behavioral health professional. And we would track those A1C improvements over time. Oftentimes, a referral to a behavioral health consultant in our practice needs a face-to-face with their primary care physician or at least a team member, because to set expectations of how the behavioral health professional will partner with their primary care team or primary care physician directly to really help them hit their goals. And it could be focused on medication adherence or diet and exercise, even showing up to referral or consultation visits. And that care plan would be unique to that individual patient. Same with community health workers, maybe they can help with social determinants of health screening, help with risk adjustment, help with medication adherence. Our CHWs here at UT help with outreach to patients at risk for medication non-adherence and assess them for SDOH gaps and connect patients to community-based resources, et cetera. Our care managers do chronic care management, amongst other things. I mean, they're very awesome, very busy nurses. But their focus is decreasing avoidable hospital use amongst our patients that are eligible for chronic care management, for example. But you can see how we are linking the activity to the metrics of our value-based contracts. But, we're not trying too hard. It's the work that these folks are passionate about doing anyway, but we have very clear lines between position and metric and activity that that need to be defined up front. All right. Finally, and this is sort of, I think I'm near the end of my time here. determining the timing for adding new staff. In terms of this last bullet point, I'm considering timing of adding new staff, but also kind of adding the very first staff member, who's focused on value-based care work as part of the integrated team, or kind of the next staff member, right? And what are the operational concerns we need to look at as it relates to these positions? And how do we think about those things? Again, it's going to be different for everyone's own organization. So what factors, do we consider here, and you probably are considering as it relates to these positions? Why do we consider those factors? And then what are potential actions to take? You can read the slide here, and we'll distribute these slides. I'll kind of highlight a few things here as I'm wrapping up. So metric improvement, right? We need to make sure that, okay, we define the metrics up front. We had our reporting process in place up front. Is the metric improving, and over what time period? That's really, really important. Organizational strategy. Change is inevitable in healthcare. I think we all know that, especially in this group. So is there a foreseeable change in focus, patient population, payer contracts? That's really important to know and to consider, especially as you are putting in the energy to expand a team or to grow a model. Market shifts, changes in payer goals, community demographics, that can really impact your overall integrated strategy as it relates to the value-based care work that's happening. Payer contracts and payout timing. This is really important. The impact of some value-based care activities, such as, well, especially risk adjustment, the impact of that work often is not felt financially until years later, maybe the next year, or in some cases, the year after that. So it is really important, especially for folks who are just interested in this space, to always be working with leadership to ensure that value-based care is a long-term strategy, not a kind of a fiscal year to fiscal year strategy. Because a lot of the energy we would expel today to make sure that we're coding appropriately and using the correct diagnosis codes in our high risk, high complexity patient population. We might see an increase in our patient complexity in our own data, but that in many cases will not be translated to financial windfall for the organization until the next contract year, or even the contract year after that in some cases. So it is really important to sort of understand payer contract and payout timing. Job market and organizational stress. So, and this is just from knowing from the front lines, especially when I worked in the federally qualified health center, sometimes posting a position can mean a lot to staff, right? It means that help is coming and help is being considered, especially for positions where it's going to take sometimes 3 to 6 months to find the right person. There are many reasons why an organization may choose to grow a certain position or to hire for a certain position. It's really important up front to be discussing what benchmarks, both local and national, if they exist, we should be using to determine whether or not a position will be added or, a program will grow. And it's really important to be transparent about that. Then lastly, again, may not matter, but productivity, right? I've seen examples where faculty, staff, clinicians fought very hard to add a certain position that everybody felt was going to be very busy and impactful. And, then that position was hired, and all of a sudden you find that, for whatever reason, patients didn't resonate well with that person, or that position just didn't meet a real need for the organization, and they were left with nothing to do. And that was, that person was not very happy. So productivity may not necessarily matter, but it is important to understand how, the supply and demand, I think, oftentimes for a certain position. So it's about 12:24, Gina. I have a few more slides, but I think this is a good stopping point as it relates to this topic. maybe I can stop there, see if anyone has any questions, or you can tell me to keep going. So I'll leave it to you guys.
You can keep going. If anyone has any question, let's just pause for a minute and see if there are any questions so far.
Okay. No questions? All right. Well, I got the chat in front of me. I don't see anything in the chat too. But I'll keep going, but please stop me if there are questions, or Sujina, if you see something in the chat. So, I spent a lot of time talking about these kind of emerging structures in terms of integrated care. It's just so important that we realize that it really needs to be a true collaboration within primary care practices for this to be successful for our communities and our patients and our clinicians and our staff, actually. And I think many of us have seen examples where it's really more co-location of behavioral health staff with primary care, not integration. And we have to work together to have those conversations on how we can fully integrate the models of care, because I think it makes a difference to our patients and our communities. One of my first jobs when I got here from Boston was really to start aligning and starting this conversation around practice transformation to align with our value-based contracts. One of the contracts that many of you might actually be aware of was DISRIP. It used to be called or now it's called TIPS, but it used to be called DSRIP, right? Delivery System Reform Incentive Payment Program, where state partnered with organizations around the 1115 waiver and really focused on hitting certain quality metrics or certain thresholds for Medicaid and low income and uninsured patients. So we basically did what I just described with you today, is we took a look at the contract and took a look at the metrics of the contract and aligned our processes and integrated many of our processes together to make sure that we were able to deliver care to our patients in a more integrated way, but also such that we were able to meet the needs of the contract from both a reporting standpoint as well as a care quality standpoint. And this was mainly a quality contract, didn't really look at cost, but it really allowed us to cut our teeth on how to do this work well. And we leveraged community health workers, LVNs, RNs, and our behavioral health team to be able to do it. Oh, I see. Is this a question?
Yeah, there's a question
Yeah.
in the chat.
Yeah. Wondering about your recommendations about getting different payers to include different models of care in VBRs. In my state, Michigan, only COCM models are included, and behavioral health, primary care behavioral health models aren't necessarily included for integrated behavior providers in some of the big value-based contracts. Wondering about your recommendations about getting different payers to include different. Okay, yeah, I think I understand the question, and in some ways many of us probably struggle with the same question, Aaron, and that question is, how do we ensure that payers are recognizing the value of integrated behavioral health providers to delivering on what these value-based needs are? And I think in the academic literature there is a growing body of evidence to suggest that the inclusion of behavioral health providers in delivering on some of these care models is key. Many of the academic, many of the literature that's out there in the academic journals, many of them had a hard time delineating, though, okay, model with and model without the integrated behavioral health provider. And here is how, here's what happened. So it's good research, but perhaps not the sort of clinical trial, we would all hope for in terms of that as a reason to getting different payers to include models of care there. Another challenge has been in terms of integrated behavioral health is sort of defining and standardizing what infrastructure expense many of these payers are willing to invest in as it relates to the full design of primary care. I'll put in a plug. I'm honored to be able to represent primary care as one of the primary care providers on the National Academy of Sciences, Engineering, and Medicine's Steering Committee on Primary Care. And we will be having a meeting at the end of this month in Washington and have invited CMS and other representatives to be able to comment about investment in primary care infrastructure. And in those conversations, integrated behavioral health or behavioral health models will most likely come up. So we'll be talking about that more directly. But in some ways, as CMS goes, as do the rest of the payers, and it is important that we define, the role of integrated behavioral health in the infrastructure expense. So that's more to come on that for sure. So great question. I don't have a great answer for you, but I think the data matters here, and and so do patient outcomes. All right. Is there another question? It looks, let me see.
There's a comment from Andrew. In Oregon, an interest group promoted criteria at the state in the middle home standards that included PCBH type activities as a payer. Then we are able to align VBC with state medical home standards that could be inclusive of COCM and PCBH activities.
Right. Yeah, and that's great. There's a big conversation about what can happen at the state level and what can happen sort of federally or at the national level. In some ways, depending on the states that you're in, there is a little bit more buoyancy and an ability to pivot in one direction or another, whereas at the federal level, that can be more challenging. That being said, when you take a look at, actually, let me show my next slide. When you take a look at all of the signals we are getting from CMS and CMMI, these value-based contracts, these value-based directions are not slowing down. They are, in fact, increasing. CMMI uses its demonstration projects to learn more and more about the models of care that work within, a fully capitated or, fully risk-bearing systems, both small primary care practices and, large integrated academic health systems and everything in between, HRSA included, the FQHCs. So I do think it's important for us to realize that this is a great opportunity for advocacy at both the state and federal level for the work that all of you are doing. It sounds like there's been great success in the state of Oregon, and maybe there should be some idea sharing, amongst, let's see, Andrew and Aaron, about what has worked for them. But, that advocacy path and piece really matters. Going back to my time at Mattapan in Boston, Massachusetts, we met with our local representatives to be able to find funding within the state budget for our integrated behavioral health program. So for many years, that integrated behavioral health program was a line item on the state budget. And it wasn't, and it had to do with the relationships we were developing, at the city level with our representatives in the city of Boston and in Mattapan. So these things often have to happen at multiple levels, both sort of clinically and in some ways through advocacy to really make these things happen in a big way. But, I can go on and on about that. But really good to hear about the work in Oregon. And maybe we should connect offline to see kind of how you got that done. Because the mechanisms are different at every, in every state sometimes. So, all right. Any other questions? All right. I'll keep going. I've only got just a few more slides and to wrap up here. Future directions. I think many of you are already aware that the ACO REACH program went into effect last year, which really looked to, again, build on the experience of the MSSP ACO model, but layer on sort of an effort to do a better job at the risk adjustment piece that I talked about through the lens of health equity. And so many organizations have REACH ACO model organizations now as well. But as many of you know, we still have work to do, right? We sort of moved from this idea of the triple aim, around care, health, and cost. The triple aim sort of shifted into the quadruple aim because we forgot about the impact of the triple aim on our healthcare teams, right? And it's the healthcare teams taking on the work of achieving the triple aim day after day, sometimes after hours and on the weekends. I think many of you can attest. We're now sort of moving in the direction of the quintuple aim, where we look at the triple aim and the quadruple aim through a new lens of health equity, and how can we do this work to ensure that the work we are doing is not leaving anybody behind. And I think that's an important component, especially when we know that a lot of the variation and poor outcomes in healthcare, while we like to think, and I like to think as a physician, that a lot of the work I do is sort of the important work. Some evidence would suggest that 40 and in some cases 80% of the reasons patients have poor outcomes, health outcomes in the world, have to do less with the health issue and more to do with social determinants. And so the work that a lot of our integrated behavioral health teams are doing really are also helping manage patients that are experiencing a lot of these social determinants of health. And we have a lot of other work to do in healthcare, right? In addition to social determinants of health, we are still having access issues. I do a lot of work with our cancer center here, and we're looking at value-based contracts for doing cancer care well, especially in a high-risk, high-need patient population who are sick. We're looking at increasing levels of what is called asymmetric information. This is where, the information that the physician has is different than the information that the patient has, and that's different than the information that the payer has, and not being able to easily share this information with each other when we're developing care plans is impacting our ability to take care of patients well. But I think the solace I have in terms of many of these challenges is that as we are learning as a country in how to do value-based care well, there are still opportunities to change minds and to influence not just strategy and activities at the organizational level, but honestly, policy at the state and national level, as we've already touched on. And that's really important as it relates to how we're defining primary care, right? One last note here, and then my final slide, I think, is another challenge, especially for many of you who are leaders and managers. Well, we're all leaders and managers, no matter where we are. But you oversee teams of people at your organizations. One thing that I sometimes notice, especially in folks that are very early on in their value-based care journey, is operations and clinical decisions, unintentionally so, become very rigid-minded. This is the metric, this is all we can think about, and so this is the process, and that's the only right process to follow. In some ways, these metrics are rigid, right? They're in the contract. They are sort of defined by CMS. They're defined by the payer or the state organization. But it doesn't necessarily have to be trickled down and turned into rigid work. Our frontline staff often have the best ideas in terms of how to achieve goals, at the local and organizational level. And, I would just kind of put it out there that rigid metrics do not need to mean rigid work for our, highly trained, highly valuable staff and faculty. All right, I think that's it. Just want to thank everyone for having me today. Primary care, including our integrated behavioral health teams, has really found itself, I think, in a really dynamic but exciting time. Lots of changes everywhere. The new types of incentives are giving us a lot of options in terms of how we put forward the best care model for our patients and our community. And, over time, I think we'll figure out the best way to deliver care. I don't think that it's going to be, I don't think it's going to be this thing where something that works in, I don't know, Portland, Oregon, is also going to work in South Texas. I think we are going to have to go in with an open mind, although we might have very similar programmatic goals. But thank you, Dr. Crow, for helping me, or for inviting me today and helping me meet this team. Really appreciate everything you guys are all doing, and really look forward to connecting after this if anyone wants. I'm here for that. So I think that's all I have. Sujina, Dr. Crow.
Thank you, Dr. Hensey. Now, are there any questions?
I wanted to just first make some comments and then raise an issue that you brought up, Ramon. And so thank you again. This was a totally superb overview. And I almost wish we had had this earlier during the whole value-based care Project Echo series. It really helped to solidify a lot of the thinking behind value-based care. I've had the opportunity to, in my internal medicine career, do both sides. I've worked as a primary care provider for decades, and then I've worked also in managed care. And so as you were going through this, I was thinking about, both aspects of that. And there's been a lot of media attention to Medicare Advantage health plans recently in the issue about risk adjustment. And I wanted to dissect risk adjustment a little bit from, my perspective and see how much you agree with that. And that is that Medicare, CMS rewards payers if they're caring for a more complex population. But that requires documentation from the providers that they are indeed caring for complex patients. And that puts the onus on the providers who are in the room examining somebody to recognize that this patient that has poorly controlled diabetes, prior amputation, chronic kidney dysfunction, and retinopathy, you got to document all of those things in order to document how complex this patient is. And you have to then be reminded in the EMR to use the HCC codes that go along with those in order to document those complexities. Some providers do a good job of doing that by risk adjusting and then rewarding quality benefit bonuses to provider groups to document complexity. But the providers often don't feel that reward. They aren't given the feedback, you're doing a great job of doing this, keep it up, versus those that don't do a great job of documenting complexity. And because of that, I think where the payers got dinged in the press was that they were actually seeing the need to send nurse practitioners out to patients' homes, record complex diagnoses that went in and above what providers are documenting. And that's you know, they got accused of upcoding. But in reality, I don't know where the balance is. The providers don't see the benefits in spending the time to document complexity, but they need to in order for the payers to provide better quality bonuses to the provider group. So I just wondered what your thoughts are about that.
You got another hour, Dr. Crow? I think of three things I think, you know, that come to mind. You know, number one, I think it's sort of the rules of the game that we created for ourselves here to do, you know, that's kind of the only way we know how sick these patients are, let alone a hospitalization event or a patient calling the payer themselves about what their diabetes is. So it's challenging. That's number one. Number two is, if these are sort of the rules of the game, and if any organization wants to play the game well, we need to, and again, this is my bias, we need to think about a way to operationalize that activity with as little of an impact as possible on the frontline clinician that is doing the work. And some organizations have figured it out. Some organizations have not. When we think about the burden, I think some folks are feeling from the electronic health records that they're sort of living in these days, I think this documentation piece is often part of that, right? So these things in some ways are linked, intended or not. So that's kind of the second thing is, I mean, I find it as my responsibility as a leader to say, okay, if this is the rule, how do we operationalize this so that our clinicians, number one, don't feel it as much. And number two, to your earlier point is, you know, how do we give great kudos to those folks who are sort of doing better than others? And then I think the third thing is also true. I think there is a risk of gaming this system, and you know, to go from an average risk patient population to the highest risk patient population in a community in the span of a year or a year and a half probably does raise eyebrows and red flags. But when you incentivize organizations to do such a thing, you know, you're going to get the result of that incentive, you know, 90% of the time. So, you know, I think the third point is how we communicate the importance of doing something like this to our teams on the ground is really important. because it is important. It is easy to go down that slippery slope of, you know, using a diagnosis code that isn't clinically true, or in some cases even relevant to a visit. And I think organizations need to balance those conversations really well. So those are kind of my top 3 thoughts around that, Dr. Crow. But yes, we watch, you know, what's happening on the MA side pretty closely, and are aware that coding intensity is, you know, a topic that is regularly addressed nowadays as it relates to both the work at MA and the MA plans, and then CMS and the ACOs as well.
No, that's awesome. Thank you for your comments. Appreciate it.
Any questions before we close?
All right.
All right, I think we're good. Dr. Cancino, thank you so much for your time and for this amazing session today. It was really very informative for everybody. Victoria, I'll pass it over to you to close.
Yeah, so as you all know, I will be sending out a follow-up email, and this will include Dr. Cancino's slides, the recording of today's session, as well as the evaluation survey. So in order to get CEU credit for today's session, you have to submit an evaluation survey. So just please keep an eye out for that email. But that's about it. Thank you so much, Dr. Cancino, for joining us today. And thank you everyone for joining. Have a great day.
Thanks, everybody.
Thank you.
Thank you.